Live, please.
So, good afternoon, everyone.
Distinguished colleagues and vice presidents.
On behalf of AI Scientific Committee, I welcome you all for Module 3 of this Video Assisted Certification course. When the going gets tough, the tough get going. This is one problem, many solutions. And today in Module 3, we have challenge of posterior polar cataract. We all know
posterior polar cataracts, they are a nightmare for any phaco surgeon because of the weakness in the posterior capsule and the high propensity of having a posterior capsule rupture. So today we have with us masters in dealing with this kind of complicated situations. We have Dr. Naren Shetty from Narayana Netralaya, Bangalore. We have Dr. Saurabh Patwardhan from Sangli. We have Dr. Kumar Doctor from Mumbai. And we have our expert panel, Dr. Rajesh Sinha from RP Center, Delhi. We have Dr. Shirish Kumar from Coimbatore, who is a prolific surgeon, and Dr. Arup Chakravarti from Trivandrum. So they will be giving their expert opinion. And thanks to moderator of this session, Dr. Amita Kaul from Delhi and Dr. Nilesh Kumar from Bihar. And thanks to coordinator of the program, Dr. Vanashi Nair from Cochin. So with this, I hand over to moderator of today's session, Dr. Amita and Dr. Nilesh.
Good afternoon, distinguished colleagues and fellow eye surgeons. We welcome you all to When the Going Gets Tough, the Tough Get Going. This video-assisted certification course has been empowering like you to conquer the most challenging phaco scenarios. And today is about phaco in posterior polar cataracts. And like Dr. Harshul just mentioned, these cases test our precision, patience, and our prowess like few others, where one wrong move can turn tough into treacherous. But fear not, we have assembled a stellar faculty, true masters of the craft who will share their battle-tested techniques, intraoperative pearls, and strategies to navigate the capsular fragility with confidence and success. So get ready to level up your skills in these high-stakes situations. It's an honor for me to be welcoming to the podium Dr. Naren Shetty, sir. Sir is the Head of Department, Cataract and Refractive Surgery and Director, Narayana Netralaya. He's a PhD from Maastricht University, Netherlands, and has a fellowship in Cataract and Refractive Surgery. He has done over 28,000 cataract and refractive surgeries, has 44 publications and 24 live surgeries to his credit. And I know, sir, if I keep going, I can keep going for 1 hour, but then I'll hand over the mic to you and let your work do the talking, sir. Welcome, sir.
Thank you so much, ma'am. On this onset, I would like to thank Dr. Harshul and AOS for giving me this opportunity. Let me share my screen. Is it visible?
Yes, sir.
It stopped now.
It stopped now?
Lost it again.
Is it okay now?
Yes, sir. No. I think you need to reshare, sir.
Yes, no, sir. Is it visible now?
Yeah, it's
Yes.
now visible.
Okay, super. All right. So good afternoon, everyone. So today we have a posterior polar cataract, and to make it a little more interesting, there is PCR even before we start. So clearly you can see from this video here in the OCT, you can see the posterior capsule is not complete. There is a dehiscence. So in these cases, you need to be very careful. I'll walk you through it. Now, one of the things is to have a good central rhexis, because in these kind of scenarios, you might require an optic capture. So you need to make it central and a little bit smaller, maybe about 4.8 or so that if you want an optic capture, you can do it. Always remember, remove the viscoelastic and do a hydrodelineation, because don't ever try to do any hydrodissection, because this already the PC is ruptured. So if you see me, I'm operating at 22 IOP, so there's not much of raised intraocular pressure. And the technique here is, let me just stop it at different points. Just hold on. So if you look at this, is my first chop. Once I've held it, I try to do it as right as possible. So I'll just play it again. I'll rewind it. So once I've got a hold, Okay, I try to do my chop as much right as possible so that my next chop is in my regular chopping position so that one piece is free. Once one piece is free, I bring it to the center and I emulsify it. So once I've emulsified it, what I do is I hold again one edge of this, make again one more chop on the right. Then I target the left. Again, once I've held it, I chop it. So that it's important to do it piece by piece because already the PC is there's a defect in the posterior capsules. So here also I'm doing like a posterior chop. I mean, or basically behind the what do you call it, the phaco probe, and then I bring it to the center and emulsify it. It's important to always keep the chamber stable. It's very important. Okay, so you can see that without rotating, I have completed removing all the pieces. So now is to target the epinuclear plate. You can reduce your parameters. It's just that I'm used to the settings I'm able to handle, but you can reduce your vacuum and flow. But you can see clearly when I'm removing this part, you can see the opening of the posterior capsule. Can you see it? Yeah. So this is the part where the posterior capsule is open. So you have to make sure that none of the pieces sink in. Okay, so I've done how much ever possible with my phaco probe. Once I've done this, please do not remove the phaco probe. This is a very important step. Fill in the chamber with the viscoelastic, and then what I do is I release a little bit of viscoelastic from the chamber and then slowly inject it. It's like visco dissect. So I'm injecting visco just under the capsule so that it pushes and frees off the epinuclear plate and the cortex. So it's much easier to remove. Otherwise, if you're not visco dissected, if you're not done a dissection, so then it becomes very challenging. So you can see here, once I've done the visco dissection, gentle visco dissection, it is the epinuclear plate is free. So you need to be very careful, very slow, so that don't let it to fall behind or into the vitreous. So what I do is I use, this is one very useful thing about the bimanual. You can use two, it's almost like as if you have two hands in the chamber. I free it up from its attachment from the capsule, bring it to one corner. Once I bring it to the corner, so I'm just keeping and slowly trying to phaco. Even if you do it slow motion, it's still okay. It should be a very controlled way. So as you can see it, I'm bringing all to one corner and crushing it onto the aspiration. So you need to take your time. Do not hurry this part because this is when you get very impatient. So I'm just standing in one position, bringing it to the corner every time. I'm using my irrigation to now and then just tuck it in. And you can see it slowly, all the pieces are coming in. So even the last piece I've removed. Now what I've done here is I'm not using my regular bimanual. So what I'm using is my cutter. So I'm using the cutter, but in IA mode. So what happens is if there's any vitreous, I don't need to change. I just immediately use my cutter to cut IA mode. And when there's no vitreous, I use the IA mode. So you can see me, I'm just slowly removing all the cortical matter. And once I've done that, is my eye. See this step, definitely see what I'm doing is under saline. It's just that I don't want to again put viscoelastic and try to remove it. It's a longer process, and I feel like this is more neater. Definitely, I wouldn't recommend it in the beginning. Always put viscoelastic so you have a better control of the IOL. But here you can see me, I'm implanting it under irrigation itself. Make sure the leading haptic is under the anterior capsule. Just I'm doing it as slow as possible so that everything is controlled. There's no visco in the chamber. Slowly, one by one, I tuck in. I make sure my the leading part of the optic is under the anterior capsule. Don't let it to go under the what do you call it, the posterior capsule. Before all of these stunts, because I already knew where my defect of the posterior capsule is with the OCT image. So with that knowledge, I looked at, okay, my toric lens, if I position it, what the position of my haptics will be. And that's when I said, okay, fine, I think this patient, we can place this toric lens. Anyway, moving forward, you can see me tucking in the lens. Now, slowly, you need to be very careful and slowly tuck in the trailing part also. Once I've done it, then I'm again under irrigation. Everything is under irrigation. So no visco, you don't need to remove any viscoelastic at all. And then I just align it. You can see the nice markerless overlay system, and this makes it so much more easier. And you have a good centered the toric lens even in these kind of compromised. So even when you're trying to remove your instruments, so this is how the post-operative looks like. So even when you remove your instruments, if you saw me, I can just show you again. So when I before I remove my irrigation, I always hydrate my side ports and main ports and then remove it so that the chamber doesn't collapse. Because sometimes in these scenarios, vitreous can again collapse. So once I've done that, I think in these cases also, torics are extremely stable in these scenarios and they do very, very well. I take this opportunity to invite everyone to his master's voice. That is happening in July 2026. So please be there. I'm sure it's a very interactive conference. I'm sure that we can exchange a lot of ideas and discussions. Thank you so much.
Thank you so much, sir. I think Dr. Amita is not there, but it was a really good show and really shows your skill as well that you implanted a toric IOL in such a scenario. I just wanted to, before we start the discussion, just as a beginner surgeon, I just wanted to understand, do you have counseled the patient also that there is a situation where we might go for a three-piece sulcus fixated IOL or something like that?
Absolutely. I think that is the norm, no matter the status of the posterior capsule, even if you have an intact posterior capsule on OCT, that has to be part of the counseling that, look, we are going to try this IOL, but there is a chance on the table I won't be able to place it. Only if there's good support, I'm going to place it. Otherwise, we'll just go with the three-piece IOL, and that should do fair enough with an optic capture. Definitely, I do counsel, and we have to compulsory have a three-piece as a backup for these kind of cases.
Thank you so much, sir. So, Rajesh, sir, I'll take first comments from you. How do you feel like when the posterior hyaloid phase is intact versus when it is ruptured? How does it differs during such pre-existing event?
Yeah, I'll come to that. But before that, I would just like to say that there are two things that was very nicely highlighted by Dr. Naren, and I would like to highlight those two things because these two things are very important. One is that the rhexis size should be slightly on the smaller side. Therein, there are two advantages. If you are implanting a multi-piece lens, you can do an optic capture there, or in case there is a high amount of toricity and the patient does want toric lens and the axis is aligning along the tear, then if it's a small rhexis, then you can put the IOL and then you can do a reverse optic capture and then keep the axis in that direction. So for that, you need a smaller rhexis. That is one. Point number two was very nicely demonstrated and mentioned also was when he did the first chop, that was more towards the right, so that you have a piece free and then you can take it out. And then without rotating, if possible, you can chop on the left and chop on the right so that you can take all the pieces. And the last one, even if it moves, then doesn't make a difference. But before that, it should not move. That is important. Now, coming to your question regarding, and one thing I would just be a little hesitant in these cases is that, when you are doing implantation of IOL, I would prefer putting a viscoelastic because when you're doing a hydroimplantation, the risk of hydration of the vitreous is high in such cases because the fluid may go posteriorly. So that is one thing which might cause some problem at times, and you may get some vitreous strand coming up, and then you have to do a vitrectomy. Now, coming to the question that, if you have an intact vitreous phase and or if it's a broken one, vitreous coming into anterior chamber, if there is vitreous coming into anterior chamber, of course, you have to do a vitrectomy. Now, vitrectomy can be done by two ways. Either you go posteriorly. You can do a hybrid technique. You can use a irrigation from anterior side and put a pars plana vitrector. The other thing is that if you're not at all very confident about using a pars plana route, then if you're using a vitrector, then take the probe behind the capsule, posterior to the capsule, so that it pulls the vitreous into the vitreous cavity, whatever has come up anteriorly. If it's an intact vitreous face, once again, as I said, I would prefer using a viscoelastic so that it will stay on it, and then you implant the IOL. You can remove the viscoelastic easily. High viscosity viscoelastic comes out easily. You have the idea is that if we can do a little bit lesser irrigation, then that might be perhaps be more helpful. But in this particular case, it went absolutely flawless. So I must congratulate Dr. Naren. Every point that you mentioned was really, absolutely bang on, that this is what is needed. And the pre-existing tier is again, the configuration is exactly the same. When you have a pre-existing tier, it tiers like, fully to the full extent. So it was nicely demonstrated. Thank you very much.
Thank you
It
so much.
also showed, this case also showed how meticulous and magical Naren is. Very nice
Absolutely.
Naren. Dr.
Absolutely.
Shirish?
Yeah, I must congratulate him. He's done a wonderful job. This is very nicely done. Knowing that there is a PC defect, he has handled it very well. And all the steps, most of the steps, I would have done the same way what Naren has showed. I slightly differ. Like nowadays, I have started doing mechanical delamination instead of hydro delamination. I use the chopper, the long chopper to create a delineation that is a nucleus from the epinucleus, the endonucleus from the epinucleus, and then I chop the nucleus. I do a Y-shaped chopping. I create a Y-shaped trench like what Naren has showed, but the proximal end, that is like which is uncut, that can be manipulated using two choppers. I use two choppers to chop mechanically the proximal end, that is towards your end. So that you have four pieces, so then it becomes very easy for you to emulsify it. So that's what I usually do nowadays. And mechanical delamination works very well, and it prevents accidental seepage of the fluid into the subcapsular space and other complications which are associated with it. And hydro implantation, I do not have done. I inject visco and do a implantation. And once if the highlight phase is intact, by pressing on the lens, most of the visco will come into the anterior chamber, and I can aspirate it. That's what like then other steps are same, like maintaining the anterior chamber throughout the procedure, and side port irrigation towards the end of the surgery. All those things is almost the same. Mm.
I'd just like to add one sentence. What Dr. Sirish very nicely pointed out, that mechanical delamination. What I have felt is that if you inject little bit of fluid between the nucleus and the epinucleus, and then do mechanical delamination, it becomes easier. So I do a sort of a hybrid kind of a combination. I do mechanical, but first I put a little bit of fluid. It creates a little bit of small margin. You are not seeing the margin, and then you can do a mechanical delamination, and that works.
That
Also,
can be
sir,
done.
also, sir, I think this is one place where clearly, especially if the sclerosis is on the higher side, where you're not able to do a hydrodelineation, a femto, cylindrical chops make a huge difference, because this is a very clear-cut, very specific case where femto is far superior, where you have difficulty like these bound or a very hard NS4 cataracts. You can't do hydrodelineation. So in those scenarios, you can do a wonderful cylindrical chop, and then with the femto, and then it makes life so much more easier in the on the table when we have post femtos.
That's very true.
Thank you so much, sir. I'll just take a quick comment from Arup, sir. Sir, I would like to ask you about the case, as well as one question for you is the choice of viscoelastic agent that you will use to tamponade at that pre-existing dent.
Yeah, thanks a lot, and uh, congratulations, Naren, for a wonderful case. Unfortunately, I cannot have the video on. If I get the video on, my connectivity is not too good. See, a few comments that sound a little which I felt was a little different from what I would have done, is not used hydroimplantation. Hydroimplantation is a good technique, but in this kind of scenario, I may not be able to. If these are all young patients, some of them are apprehensive. Little bit of squeezing from their side, can result in the rupture of the anterior vitreous face. So I would use a OVD into the anterior chamber to form the anterior chamber, and this will be a viscoat, converting sulfate. It would be a dispersive OVD. Dispersive OVD basically stays it stays in the place, and it tamponades the area of the PC rent. And even if you leave behind a little bit of the visco at the end of the surgery, the post-op ocular hypertension, it doesn't give that big a spike, and which can be managed maybe for 1 or 2 days. So that is the difference that I would have done. And then I don't do any delamination. I just go for a chop for this case. Hydro-free dissection using a cyclodialysis spatula. Then just go for this was a little sclerosed cataract. So I'll make a pie-shaped, chisel out a pie-shaped part of the nucleus from the nasal side and from the central area. And once the bag has been decompressed and you have created a space in the bag, then you can by that time automatic hydrodissection would have taken place. Fluid, so much of the fluid which is in the anterior chamber would have percolated between the lens matter and the anterior capsule. So it is not difficult to mobilize the nucleus. Otherwise, you can always you can rotate your wrist, and you impel the superior part of the nucleus, bring it to the center, chop it, and then you can do the same thing for the inferior side also, to if you don't want to rotate the nucleus. One question for Naren was, now when you start, I joined a bit late. So when you started off Phaco, I do not remember I didn't see what was your IOP. When you had the PC rent and you saw, I saw the IOP was 55. So when you see a PC rent, with or without vitreous disturbance, how do you adjust your parameters?
So the thing is, sir, in my surgery, usually all surgeries I keep it 22 IOP, sir. Even in this case, IOP I keep it as low as possible because already there's a PC descent. I don't want to create any more pressure on the posterior capsule. So
I thought I saw 55 on the IOP side.
that was IA, sir. In
Oh,
IA,
that was IA? Okay.
that is IA, sir. Usually because the holes are a little on the smaller side, you need a little on the higher IOP to compensate because the key thing is when we have a compromised posterior capsule, it's very important not to fluctuate. It's not that you have to keep 22 IOP. If the machine is able to handle it and without fluctuation, it's fantastic. But if it is fluctuating at 22, definitely it's a bad idea. It's important to keep at an IOP where the chamber is stable, no matter what machine.
Yeah.
Because the whiplash is where you can break the hyaloid phase and the vitreous prolapsing. All those complication happens. So it's important to maintain a stable chamber at all times.
Thank you.
Thank you very much,
Thank you
Dr. Naren, for that sharing that wonderful video. Can you move ahead, Dr. Nilesh?
Yes, sir. And next, I'd like to invite a teacher par excellence, I think, for those youngsters who are learning cataract surgery through YouTube. Sir has been Dr. Saurabh Patpadal, sir, has been one of the pioneers. He is head of Phaco training and director at Nandandeep Eye Hospital and PG Institute. And he has numerous, like, we can't, the allocates are too much to enumerate before the webinar, but sir is a master with around 1,48,000 subscribers and counting for his channel. So I would like to invite sir for his talk on posterior polar cataract.
Thank you, Dr. Nilesh. Am I audible?
Yes, sir.
Yes.
Completely audible.
Yes, thank you, Dr. Harshul, for the invitation. I will share my video. 1 second. I can't see the option of sharing video.
Do you have it on the screen, sir? The bottom 6 o'clock green button should be there. Or just click on more button, which should have 3 dots.
Okay, I'm on a Mac. Okay, it's asking me for permission. 1 second.
Okay.
Yeah, okay. Now is it audible? It's visible?
Yes.
It's visible, sir.
Okay.
Yeah, should I start?
Yeah, please.
Yes, sir. Yes, sir.
Okay. Is the audio there?
So in case for the audio on the floating bar, just click on three dots. And you will have an option called share sound. Just switch it to mono or stereo, whichever is comfortable to you.
Should I stop sharing and again?
Yes, please.
Okay, sorry.
Or once you click on share, you will right hand side, you will have a share sound option. Just check that box.
Got it. Yes.
Thank you, sir.
I'm sorry. I'm not used to the Mac. So. Okay. I think audio is still not there, right?
We are waiting for it to be played, sir. No, audio is, you've minimized the audios or?
Video is
the audio
there?
is not there, sir.
Video is there?
A video is there, sir.
Okay. So then I will speak, I think this. Okay.
Yeah.
So thank you so much. I think Dr. Naren showed most of the basic things which are, we have to monitor during tackling posterior polar cataracts. Now, when we say posterior polar cataracts, many times we feel that it is a single entity. But here, I think what is very important is this OCT-based types, which were given by this paper by Professor Titial sir with his colleagues. And I feel that this changes the management in a big way, because if you do anterior segment OCT and make it into these three types as per the paper, type 1 is where there is an intact PC. Then it behaves almost similar to a normal posterior subcapsular cataract. In type 2, there is an intact PC, but there is a opacity and shadowing. Like I will show, this is type 1. You can simply see the entire PC on the OCT. And in these cases, the chances of PC rupture are like 1% or less. While type 2, here the chance of PC are a little more, where the PC is slightly obscured by the dense opacity which is there. But even in these cases, many times the PC appears intact. Type 3 is where you can see little bulge into the Berger space there, and you can't really see the PC. Now, these are the cases where the chances of a PC rupture are more. And I have described a type 4, which I have seen in few cases where the PC has already ruptured. You can see that the lens matter has already gone into the Berger space. Now, let's try to understand it through some animations. Like in type 1 PPC, you see a opacity on the posterior subcap on the capsule, but you see that the PC is intact. In type 3, there is a bulge, but still you may not have actual rupture of the PC. While type 4, there is a rupture, and you can see that nucleus matter is in the Berger space. Now, when we compare posterior polar cataract with, say, post-traumatic cataract, the difference is that in posterior polar cataract, no matter what is the grade, like type 1 or 4, the anterior haloid will be always intact. Well, in case of post-traumatic cataract, even if you see similar opacity on the posterior capsule, there is a chance that anterior haloid may be ruptured. So what can cause rupture of anterior haloid in PPC? That is most important. So one, we have already know that hydrodissection, if you do exuberant hydrodissection, it can not only cause PC rupture, it can also cause anterior haloid rupture and can cause nucleus drop. Another thing which can cause it is raising anterior chamber pressure too high. So low IOP Phaco is, I think, one of the essential requirement for tackling posterior polar cataract. Now, this is a type 4 PPC. As you can see that the PC is already ruptured, and you can see that nucleus matter has gone into the Berger space. Okay, this typically, many times we see these in younger patients. Even when we are operating young patient versus old patient, there is a difference because scleral elasticity is different as the age progresses. Now, as rightly said, we have to target 4.8 millimeter capsulorhexis. Why 4.8? Because when we are using any IOL of 6 millimeter size, 4.8 geometrically is the best size to have the perfect optic capture. Now, this is something, I think I've seen it, Dr. Arup sir doing, and after that I started doing this mechanical dissection in one of the videos he had shown. And here I am using that large spatula, and the most important thing is you have to go till the equator and you have to cover 360 degree, because even if you miss, say, one clock hour, you will find that the entire epinucleus is stuck at that point and it takes long time to release it. I've done hydrodelineation now. Soft cases are easier to tackle because you don't have to really chop or divide. You can just go layer by layer and aspirate it completely. And because you have done good hydrodelineation, which is not possible in harder grade of cataract, in this case, it is possible. So it usually separates from the epinucleus and you can just remove. OVD BSS exchange has to be done at every time you're coming out. Now, as you can see with the mechanical dissection that I have done, you hardly have any problem in releasing that epinucleus from the periphery. So good mechanical dissection is essential to reduce that, effort that you need to remove this epinucleus. Now here what you see is the posterior capsule is already breached there that at the center, and there is opacity at the center. So I decided that I will convert it first into a posterior capsular axis so that I can place easily in the bag, the IOL. So, and that opacity which I thought was on the posterior capsule has actually gone onto the anterior and that's why I decided to do some antivitrectomy and release that opacity. Sometimes you can leave little bit of opacity, it may get aspirated later, or you can do YAG laser. But if you feel that opacity is big enough, then you can just typically do antivitrectomy localize, and then you can place the IOL in the bag. So here you can see the IOL is placed in the bag and the posterior capsular axis can be seen. And the central part is clear. You can also enlarge the posterior capsular axis a bit if you feel. This is post-op after 1 month. You can see that the posterior capsule is now quite clear. Most of these opacities get absorbed by that time. Now I'm showing another case where it's a type 3 PPC, but a very old patient, 81-year-old patient. And this patient was diagnosed posterior polar cataracts some 25-30 years back. And because patient was told that there is a high risk of complication, patient didn't go ahead with the surgery at that time. And as age advanced, the nucleus process increased. Now, these are the cases where hydrodelineation is very difficult. And these are the cases where I use the oval rhexis, which is described by Dr. Kiranjit Singh. This oval rhexis is useful for these cases because in case of PC rupture and particularly old patient, the anterior haloid may not be that strong and vitreous may be liquefied. So in such cases, the chance of nucleus drop is high. So if you have a large oval rhexis, one, the resistance to remove this nucleus, if you are converting to scleral tunnel and removing, is easier. And also the optic captures become easier. So this is the over capsulexis technique by Dr. Kiranjit Singh. It's a very useful technique, particularly if you are dealing with harder grade of cataract with posterior capsular dehiscence. Now, the technique involves that on one edge, the capsulexis should be at least 5.5 to 6 mm. On the other side, it can be around 4.5 or maybe 4.8. So on that axis, the smaller axis, you can then do the optic capture later if required. Now, again, the mechanical dissection has to be very, very thorough in these cases. So make sure that you note down all the clockers you are covering with the mechanical dissection, and both the sides it should overlap. So you should start from other side and complete the mechanical dissection till the end so that the epinucleus never gets stuck. So this is the thing. Many times I see that if I hurriedly do mechanical dissection and even if I keep little bit of attachment of this epinucleus with the capsule, then you are stuck. Now this is the sideways sculpting method which I have already published, and this is very useful for posterior polar cataract, particularly with higher grade. So here, as earlier mentioned, that we avoid nucleus rotation. So now how to do? Either you can do the chop in the same, like Dr. Rajesh sir was telling, that stay at the center and do right and left chop, or you can do first do a deeper trench in the center, and then rather than rotating the nucleus that you usually do, you have to move your phaco tip sideways. So you do a sideways trenching here. I use the same technique for cases where my trainees or fellows, if they have a complication where the capsulexis has run away or something like that, then to avoid the nucleus rotation, I use the same technique, and it gives very good result because the chances of even the anterior capsular rupture going back is very minimal with this technique. So once I have done this 4 quadrants here, what I'm going to do is not divide the nucleus completely, through and through, but rather I'll be dividing only till the central part. So I'm going to divide only the peripheral part. Here you can see that I'm dividing only the peripheral part very carefully, keeping the central part intact, because this is the part where there might be a dehiscence already. So in such cases, if I try exuberantly divide it, then I might open up the PC right at the moment. So here I'm dividing only the peripheral part of the nucleus, so only the central part is attached. Now, after careful division, I'm going to remove one by one. Here, importance is of low flow. So I have done, you can see that I have reduced my flow rate to 30. So what I've seen in this, even with when IOP is 20, if I use very high flow rate in this, quadrant removal, particularly with active fluidics, it tends to push lot of fluid in the bag when the IOP starts going down. So it is very important that you keep the flow rate very low. Otherwise, that gush of fluid itself may be enough in cases to cause PC rupture. So I have reduced the flow rate to 30 and reduced the IOP to 20, and I'm removing the nucleus from the anterior chamber. Now, whenever there is a subincial nucleus, it's always important that you take a pause, because if you try exuberantly remove it and try to rotate it, sometimes it itself may cause posterior capsule rupture, and particularly in old patient, because the anterior hyaloid may be weak and the vitreous may be liquefied. It hardly gives you any time, and nucleus just drops into the vitreous very quickly. So here I have taken a pause and I'm using two Sinskey here to just pull out the nucleus into the anterior chamber. So without rotation, I just pulled it out into the anterior chamber. Use good viscoelastic agent, dispersive OVD, so that the endothelium is well protected during this maneuver. And again, I have kept the flow rate very low, and I am going to emulsify this remaining quadrant. So I always say that posteropolar cataract is a game of 100%. So even if in 99% of your maneuvers, if you are correct, but in 1% you make any mistake, the posterior capsule is just going to open and the nucleus might just drop. So you have to be careful all throughout OVD BSS exchange. As I showed, you have to patiently do it every time you go in and come out. So that is something very important. Take your time, particularly these harder grade of cataracts. They might be time consuming. So many times we edit and show these videos in 5-10 minutes. Sometimes it takes 20-30 minutes to complete the case. But make sure you have that patience to complete the case without any complication. So this is the last piece which I'm going to emulsify. You can see that I'm still patiently making sure that viscoelastic is well injected. I'm pushing some dispersive OVD over the PC, so the PC remains intact and well protected, and then I carefully remove this last part. So as you see, this was the type 3 PPC with very dense cataract. The PC I could see that is papery thin, but I could remove it completely and place the IOL in the bag without any issues. So these were a few things which I would like to add. One important thing was the OCT-based classification. I think that is something we must adapt to in our clinical practice. So thank you, Dr. Harshul. That's all from my side.
Thank you so much, sir. I think that was a really good selection of two cases, but very useful tips in those two cases, and very well pointed out, sir. I think the use of anterior segment OCT should increase in such cases. So that is your comments, please.
Well, it is always a treat to watch, Saurabh. Your videos are fantastic. And I must tell you one thing. I mean, you pointed out all those difficult things and all those tips and tricks that should be followed. Yeah, I really liked your sideways sculpting. That was really very innovative, and I really, found it. I felt that it will be really very useful, because I do sideways chopping, but the sideways sculpting also is something which is a very good idea. One thing I just felt that when you were dividing it, you were using one chopper and the one instrument. Uh, can we also inject viscoelastic and use two choppers to separate? So there will be you'll have a more controlled separation with the two choppers, and I mean that is something that one can think of. And of course, ASOCT based classification, as you mentioned, is something very useful, very useful paper. Many congratulations, Saurabh. It was wonderful.
Thank you, sir.
Thank you, sir. Shirish, sir, please, your comments.
Very nice teaching video, Saurabh. And do you do this ASOCT routinely for all the cases nowadays?
Yes, sir. Yes. The reason,
Yeah.
because we do a lot of trainings as well as in fellows, and most of the time these posterior subcapsular cataracts are typically diagnosed as PPC by many of my residents and fellows. But once we use ASOCT and we see the PC is intact, actually these are like normal cases. So Many times, in fact, I feel that actual like true PPC are really rare in our practice. Most often, what we see are presumed PPC, that is the type 1 PPC. And as I said, if I see my series, the chance of PC rupture is almost zero, like a normal case in these cases.
No, like we have done a study which was published last month in like we are using the SOCT anterior for all the cases of PPC before surgery. We do it, and like we categorize them. Type 1 is actually safe. Actually, we have done the regular hydro dissection and minimal rotation in all the cases of type 1 PPC based on ASOCT. And only out of 71 cases, only one patient had a PC rupture. It is safe. So, like type 2 and type 3, of course, it is risky and you can't do this. But type 1 cases, you can still go ahead and do your regular Phaco. Hydro dissection can be done and minimal rotation can be done. Of course, you have to take all the precautions, maintaining the anterior chamber and not polishing the posterior capsule. All those things you have to follow, but it can be done. Hydro dissection can be done in these cases. This is our inference, and only one case out of 71, which is less than 2% of the patients had a PCR.
I agree completely, sir. That's why type 1 PPC, yeah, just we are careful, but we know that PC will be intact. So I think that's the thing.
Yes.
Thank you so much, sir. Arup, sir, your comment. Arup, sir.
Yeah. So,
Yes, sir.
as regards Shirish, what you mentioned about type 1, why did you have a precedent? Even out of 70 cases, why one patient had a precedent? So that is number one. So
Like,
what I would
it's
do is I
not
use
that.
the anterior segment OCT to classify the posterior polar cataract so that I can counsel my patients better, but I don't alter the surgical technique because it is, see, after having done, all of you have done so many PPCs, it is not that much of a challenging situation that, you'll be spending a lot of time and all that. So I would not even, one out of 70 is, why did it happen? Why did it happen? So some situations, the posterior capsule may be very thin centrally. Normally it is 4 micron. So we are not measuring it. We are just seeing that there is a lucid interval between the posterior aspect of the PPC and the capsule. We do not know whether it is, whether it is thinned out, whether it has become more fragile and all that. So I would still alternate my technique. I would not alter my technique, but I would counsel the patient that, that's number one. And then Saurav, of course, has done a wonderful job and, there is nothing much to comment about it. Very well done.
There is one question from the audience, sir, is in harder and wide cataracts, OCT is not clear. So I would like to ask
Yeah,
this
it cannot see. In that case, we go by circumstantial evidence. So, for example, if I see a patient with a total cataract, or a white cataract, and the fellow eye has a PC with lot of vitreous, and that means lot of vitreous in the anterior chamber, ACIL or iris fixated lens, which means the surgeon was not expecting a PC and PC happened, and there's vitreous disturbance which wasn't managed properly. So I would assume that first eye had a PC, posterior polar cataract, and which the surgeon was not prepared to prepared for. So second eye, I would definitely assume that it is a posterior polar cataract, and go and deploy all the techniques that I have for posterior polar cataract. And in such situations, say for example, if it is a white cataract after a vitrectomy or after a trauma or after a intravitreal injection, then of course the diagnosis becomes very clear. It is not a posterior polar cataract, but it is posterior capsule open status. So there also you use the same strategy as a posterior polar cataract.
Yeah, one more thing in case of white cataract is that check the ACD, compare with the other eye, if other eye also. Sometimes in this PPC, you have in fact more ACD than the other eye, despite being a white cataract. So that might also have a indication. But as Arup sir said, I think the other eye gives more clues in these cases.
Thank you, sir. Thank you so much, sir. With this, we'll move to the Arshad, sir, shall we move to the next talk?
Yeah, please, yeah.
So next talk is by none other than Dr. Kumar Doctor, sir. And just 1 second. So, Kumar sir is the CEO at Dr. Eye Institute, Mumbai, and he had been the president of IRSI in 2013-14, and he's a marvelous surgeon. And if I may say so, I am more than his surgery. I am fan of his the concept and the production he brings to his videos, the Oops Buster, and right now what I saw in the last AIOC is the Bond film. So I just marvel at the production quality and the thought that goes behind bringing those videos to life. So all yours, looking forward to your surgery.
You are
So you
muted,
are on
Dr.
mute,
Kumar.
sir. So the presentation is visible, sir. The mic is off.
Now?
Yeah, yeah.
Yes, sir. Now we can hear you.
So this is life in ophthalmology and not life beyond ophthalmology. So Harshul is doing a brilliant job at both ends. And congratulations, Harshul, and thank you for this opportunity. And I'm just going to talk a little bit about posterior polar. Do not attempt an SICS. I don't think anybody is talking about SICS here, so that's good. But what would the options that we have today is flax with Phaco, there is no doubt. So I'm just going to show two videos. Here you can see a nice golden ring. So I've done a hydro delineation. Obviously, there's no hydro dissection. But here we are going ahead and doing phacoemulsification. Very important step to bring out here is once we've finished your phacoemulsification, do not just come out, which has already been highlighted. Put in a viscoelastic. So here I'm putting in methyl cellulose. Make sure that you do not allow any decompression. Once the methyl cellulose fills up the anterior chamber, and then you can bring out the phaco. Now, as far as the bimanual IA is concerned, what I like to do is always like to start the bimanual irrigation sub-incisional. Why I like to do that is in case there is a PC rent, that's the most difficult cortex to approach. So as you can see here, I'm going sub-incisional and trying to remove all the cortical matter, and do not go till the center. What I like to do is mushroom everything in the center. So leave the central plaque attached as long as possible. Do not try to remove that in the initial stages. As you can see, I always sit superiorly, and I'm approaching the sub-incisional cortex first. And don't forget, it's a small rhexis, so one has to be really careful because sometimes you may get muddled up and you may hold the anterior capsule. So be careful that you're holding only the cortex and not holding anything else. So you can see that I'm going all around, only superiorly, then going inferiorly, coming to the center, leaving the cortex, coming to the center, leaving the cortex. And that's the reason why I'm mushrooming all the cortex right in the center. So I'm not going all the way there. And same thing I'll continue to do around inferiorly now because I already released the subincisional cortex. So here I'm not going till the center. And then once you have done this, just again fill in the bag with viscoelastic. Again, change your hands and then go ahead and do that. So here you can see I've changed my hands. And once my hands are changed, you just go ahead and go and do the rest of it. So you can see the central part now has got loose. And as rightly said by Saurabh, that most of them are just near the posterior capsule. They really don't have any dehiscence through and through. And you can see that the whole thing has come out. So one has to be very, very careful as far as that is concerned. So the chamber is well formed. Always remember a small CCC because in case of a PC rent, and Phaco is the way to go, no doubt, with femto is preferable, and SIC has no role at all. So this is a pre-existing, I don't know whether you can
Posterior polar with pre-existing dehiscence. The slit lamp examination will not reveal the real story.
Can you hear the audio?
Yes, sir. We can hear, sir.
Okay.
OCT shows and confirms the diagnosis.
So as rightly mentioned in the discussion before, no doubt that OCT has to be done for every PPC. Preferably, even if the patient can't afford flax, do flax, is my thought process. So in my center, if you have any doubt, best is to do flax and you'll see why.
Patient taken for flax, CCC planned for 5 millimeter. And the posterior safety distance is increased away from the posterior capsule.
So the posterior safety distance to do the fragmentation of the nucleus, normally I keep 0.6, so it's 600 microns away from the posterior capsule. Here, as you see that I've kept a large difference. So the fragmentation is not going down. The bubbles that are created behind the fragmentation is not going to disturb the posterior capsule at all.
All steps, CCC, fragmentation, and clear corneal incision are done by flax. The capsule is pinched out. No hydro procedures are done.
So as you can see, this is a soft cataract. Just pinch out the CCC. The big advantage of flax is you can move the CCC in any direction you want. So if you are confused or worried about it, you can move that in any direction you want. And now I'm not really going to do even Phaco because it's a soft cataract. I'm just
Bimanual IA is done directly. No rotation is attempted. Since it is a soft cataract, no Phaco is really necessary. Notice the reduced bottle height with a bimanual IA. Aspiration of the central and the peripheral cortical matter goes all around. Peripheral cortical aspiration is done with the help of the bimanual IA, including the subincisional area. We had created all the incisions with the help of flax, which are pretty self-sealing. The central nucleus is aspirated with the bimanual IA. For change of hands, the aspirating port is removed. Viscoelastic is replaced in the anterior chamber. The chamber is not allowed to collapse. Then with change of hands, the peripheral cortical soft matter is removed and aspirated. The most important is the central plaque of the posterior polar cataract, which is to be handled last. Make sure that all the soft cortical matter around is aspirated before the central plaque is handled.
So this patient had a pre-existing dehiscence. Okay, we had done an OCT which I had shown, and that's what we are going ahead. So there was no hydrodissection used at all, direct bimanual, because it's a soft cataract. This is quite possible if the cataract is soft.
All the soft cortical matter that is visualized under higher magnification, which is attached to the central plaque, all around is aspirated with the help of the bimanual IA.
So as you might notice, I'm not touching the central plaque at all. We are just removing the cortical matter all around it and attacking the subincisional at the same time.
It's very important that the central plaque is handled at the end. And all the matter from all around is removed. The aspiration of the soft cortical matter all around the plaque continues. Again, with change of hands, the anterior chamber is filled with viscoelastic. The chamber is not allowed to collapse at any stage of the surgery. And the bottle height is maintained at a low level throughout. Throughout the procedure, we take care that the chamber is not allowed to collapse. The plaque is always removed last. It's very important that we remove all the cortical remnants which are attached to the plaque. So as we get closer to the plaque, the procedure becomes little slower, and the cortical aspiration, which is attached to the plaque, begins. And at the last stage, the plaque is lifted off. We have seen the AS OCT image, which really showed a dehiscence, which is present in the posterior capsule. So all the cortical remnants which are attached to the plaque are now gently being aspirated. Once that is done, we go ahead to hold on to the plaque. So no Phaco was done in this case at all because it was a soft cataract and it can be done directly with a bimanual IA. Once all the cortical remnants are removed, the plaque is gently lifted off. One can see that all the cortical remnants around the plaque are removed. And then at last the plaque is held with the aspirating port and all around gently elevated from its attachment. One can also see the dehiscence in the posterior capsule, which is present and which was diagnosed preoperatively with the help of the AS OCT. The plaque is then detached completely. The help of the aspirating port, the plaque is gently elevated and making sure that no vitreous is following the plaque. Once detached from its attachment, with the help of the aspirating port, the plaque is completely aspirated. This is followed by chamber formation with the help of the...
So one thing that was not mentioned in the discussion before, that when there is a pre-existing dehiscence, what is good news is, thank God, is that around the dehiscence, the posterior capsule is quite fibrosed. So it doesn't just run away or suddenly tear. So such cases normally have a little bit of fibrosis around, and so we don't really need to panic. This is what I've observed whenever there's a pre-existing dehiscence. So it's not a very thin, fragile posterior capsule, but it's quite a strong posterior capsule.
The elastic chamber is not allowed to collapse at all. And once that is done, we made sure that the vitreous did not follow the plaque. since the rest of the capsular bag is intact, and in the bag IOL placement and rotation of the IOL is achieved. The rest of the particle matter is removed once the lens is placed horizontally into the bag. So with the help of advanced technology like FLACS, let's look at the first day post-op image. You can see the lens in the bag in a well-centered IOL. Thank you.
So advantages of FLACS is a perfect centered size CCC. You can vary to the size you really want. You can move the CCC in any direction. You get fragmentation of the nucleus. So you really don't need to do any hydro procedure. Even if you're doing a phaco in a little denser cataract, there is no harm. You can just go ahead, approach one fragment and just remove it. No need to rotate. So no hydro procedures can be avoided. The distance from the posterior capsule, of course, has to be adjusted. As you saw in FLACS, I've kept a larger distance. And IOL can be placed either in the sulcus in case you have a PC rent. So you're ready for any complication, and you can place the IOL wherever you want. So of course, you must have a backup of a 3-piece IOL. And if everything is fine, as you saw in this case, then you can go ahead and put a single piece in the bag itself. Thank you.
Thank you so much, sir. I think that was a very good demonstration of how to use tech to your advantage and to patients' advantage as well. And I think Dr. Santosh wanted to ask how to manage primary PC plaque, and just on the cue, your video started on how to manage the posterior PC plaque. So I think that must be very helpful. I would like to invite comments from Dr. Shirish sir, and then Dr. Arup sir, and then Harshil sir for the flags.
A nicely demonstrated case wherein only irrigation aspiration was used to. So this works very well in a younger patients with very soft cataract. You won't have a formed nucleus. Maybe up to 35 years of age, we can do this technique. And any patient after the age of 40, there will be some formed nucleus, and which may not be aspirated. It is not possible to aspirate the central small core of nucleus. So in such cases, we can use a phaco. We can use the phaco aspiration mode and remove it. And then LRCS, that's laser refractive cataract surgery. Maybe like it's not affordable for all the patients, but for this particular kind of cases like PPC, and definitely we can promote because it has its own advantages in PPC. And ours is a private setup wherein the LRCS buying rate is around 10% only. Around 10% of all the cases are LRCS. So cost is one factor. So it cannot be used in all the patients. And of course, like it's very well managed. This particular patient had a PC. There is a PC opening which is fibrosed. Usually, it won't enlarge. We can safely go ahead and place a lens, multifocal lens, or a multifocal toric, whatever the lens of patient's choice, can be placed in the bag.
Thank you, sir. So, Arup sir, your
Yeah.
comments.
So Kumar, wonderful job.
Hi, Arup.
So what another option, for removing that thick epinucleus, and when so much of epinucleus is there, that there are two options. I would think about using viscoat, inject viscoat at the capsular fornix, and displace the entire epinucleus en masse towards the central area. And once the clump of the epinucleus forms at the central area, remove with the irrigation aspiration. So that will reduce the time that you require to complete the surgery. That is one option. Second option is, Sirish was mentioning that, so when you get patients with traumatic cataract patient age 40, 45, you don't have a formed nucleus as such, but you have a very thick cortex and epinucleus. So I had actually got a company to make for me a 0.5 aspiration port. So normally your irrigation aspiration, the aspiration port is 0.3 millimeter in diameter. So I made them customized to 0.5 millimeter. So it became much easier. The whole process of aspirating the sticky epinucleus become much faster. The only thing is you need to balance the irrigation that goes into the anterior chamber. Otherwise, if there is a mismatch between inflow and outflow, there will be chamber shallowing. But this is something, and I have it in my surgical repertoire. So I use that bigger cannula. And regarding the posterior polar capsular plaque, now if you feel that it is absolutely thick and you cannot yag it, you can consider to do a posterior capsular excis. And sometimes, if it is just a fuzzy kind of opacity, and there are some clear areas here and there, and surgical table, you may tend to overestimate the impact of the posterior polar plaque on the postoperative vision. And when you see the patient on the first day, patient has a very good vision. So that can be left alone. But if you're doing a multifocal lens, in that case, and I would suggest that you use do a posterior excis, remove the central plaque, and then put a lens.
Thank you, sir.
Thank
So,
you so
Harshal, sir.
much. I think Dr. Kumar, those were wonderful videos. We know he is a master surgeon. He has amazing videos to his credit. Thank you so much.
Thank you,
for being
Ashok,
here.
for this opportunity.
Yeah.
Thank you so much, sir. With this, I would like to move on to the last talk. It is by Dr. Harshal, sir. And just 1 second, I'll share the screen. So, Harshal sir, I don't think anybody will need introduction. He is leading this program, the module when going get tough, the tough get going. And sir is director at Rawat Eye and Phaco Surgery Center at Jaipur, and also at Jaipur Laser Vision Center. And he is also spearheading the Life Beyond Ophthalmology group. And sir has many awards to his credit and multiple innovations, including the invented technique of hydroimplantation and hydrostitching. So looking forward to sir's tips on managing posterior polar cataract.
Yeah, thank you so much, Nilesh. So I think we saw some wonderful videos, and I'll be like to share quickly 2 videos here. So we all know that, can you see my video here? Is my video visible?
Yes, sir, visible,
Yes,
sir.
sir. Yes, sir.
Okay, fine. So we all know that the whole game plan is to try to delay the opening of the posterior capsule as much as possible, because in true posterior polar cataract, when we are taking out the last plaque, they tend to open in a linear way, the way we saw in everyone's video, like Naren's video. So capsular axis sizing, everyone emphasized that yes, it should not be more than 4.7, 4.8 millimeters, because that is the ideal size to do optic capture in case we have an opening which is uncontrolled and we can't convert it into posterior capsular axis. So just little bit hydrodelineation in these cases, and as Naren also showed, we just take out this pi of nuclear piece, and idea is not to rotate the nucleus and try to take out this endonucleus. So once we take out the endonucleus, as we have seen, that is the layer by layer separation which has been advocated and which we all do, that we first take out endonucleus, then we are left with the epinuclear sheet. So this is the endonucleus which is gone, and then we loosen up the epinuclear sheet from all around, as Dr. Arup was also mentioning. We loosen it up from try to loosen it up all the sides so that the central plaque is taken out in the end. So once I loosen up the epinucleus here, as you'll see, I take out this sheet, and once the central plaque comes off, you can make out that yes, this posterior capsule is open here. So now at this stage, what you don't have to do is to withdraw your phaco probe or come out immediately, because now what works is the principle of closed chamber phaco, that you need to maintain closed chamber at all the stages, as Dr. Saurabh was also mentioning. So put whatever viscoelastic you have in hand. Viscoat, like chondroitin sulfate based OVD, is superior in plugging the defect which is there, but whatever OVD you have, do visco exchange and then come out. And now you have vitreous in anterior chamber, So you need to do vitrectomy first to clear out the vitreous from anterior chamber before you start doing cortical irrigation aspiration, because if you do irrigation aspiration without clearing vitreous, you'll put a lot of traction on the vitreous base, which is going to create long-term complications. So always do bimanual anterior vitrectomy, either through limbal route, or if you are proficient, you can do through pars plana if you are trained in that. So always do complete anterior vitrectomy. So once I've done, again I'm putting viscoat here and before taking out my irrigation cannula. So, and then after doing complete vitrectomy, you can see I can easily take out the cortical matter which is there. And before changing my hands, again I'm putting OVD here and take out this cortical matter from the remaining capsular bag. So you can see there's a tear which is a linear tear, which is, I can't convert this tear into posterior capsular axis. So this is where the importance of a perfect size of capsular axis is there, that if you have a bigger capsular axis, you can't capture it if you are putting a 3-piece IOL in sulcus. So now after this, again before enlarging the incision, I'm maintaining closed chamber. So how does it help is that whatever defect is there, your defect doesn't increase, and whatever vitreous is there, it doesn't prolapse if you maintain closed chamber. So this is a 3-piece IOL. Nowadays we use almost all lenses are single piece lenses which we use. So they are a little bit tricky to use. So you should be well versed how to use 3-piece IOL. Otherwise you may land up, just putting them in anterior vitreous straight away. So the trick is that always take care of the leading haptic which is coming out. Always orient it horizontally beneath the pupillary border, beneath the iris. So it's horizontal, and then rotate your hand in counterclockwise direction. And then you can dial IOL in the capsular bag in sulcus. And after putting IOL in sulcus, you need to do optic capture. So I'm just using this Kugelin's hook, and on both the sides I'm capturing this IOL. So we always tend to put haptic perpendicular to the posterior capsule tear which is there. Put IOL in sulcus, 3-piece IOL, and do optic capture. This optic capture is important for long-term stability of this 3-piece IOL. And remember that if you are doing optic capture, you don't have to do any changes in IOL power, because you are capturing it behind anterior capsule. So at the end I put Miocol, and this was under topical anesthesia the entire surgery. And you again do some vitrectomy and check for any residual vitreous strand, and this finishes the case. And I'll show you post-operative photographs of this patient. You can see IOL is nicely being captured on both the sides, and this is a large defect which was there. So this is the way you do capture. This is another case, again typical posterior polar cataract. What I want to show here in this case is, as Dr. Naren also showed, so this is the last piece which has come up, but posterior capsule tear doesn't always mean that there is disturbance in anterior vitreous phase. So the currents in the anterior chamber, the fluidic currents, they tell you, they guide you as if the vitreous phase has been disturbed now. So first thing is, you'll see the posterior capsule tear, enlarging if vitreous is coming up. So here, what I'm doing is, I've just put separate irrigation cannula on separate BSS bottle before withdrawing my Phaco probe. So I'm just maintaining closed chamber, and this fluidic movements of cortical matter also guide me that yes, there is no vitreous disturbance. And see, now I can easily, in spite of posterior capsule tear, I can do irrigation aspiration because there is no vitreous disturbance. So if you don't let your chamber fluctuate, you can prevent anterior vitreous phase getting disturbed. And but remember to keep irrigation cannula towards angle, not towards the defect which is there, posterior capsule defect. So again I am changing my hands. You can see a posterior capsule defect there, and this is complete irrigation aspiration I've done. And after I've taken out the entire cortical matter, you can make out that because anterior vitreous phase is not disturbed, posterior capsule is dancing like a trampoline there. It shows that there is no disturbance. So before putting IOL, I just do visco exchange, put a chondroitin sulfate OVD there to plug the defect, and then convert this. I could see the tear margins there. So wherever you can see the posterior capsule tear margins, you should always try to use microforceps and convert it into a posterior capsular axis. And once you have this converted into a PCCC, you can easily place a single piece IOL in capsular bag, because those are stronger margins and they won't give away. Take care when you are putting the leading haptic that it goes between two leaves, and then rather than trying to rotate the nucleus, you can just bend the haptic of the IOL and push it in capsular bag. So this way you can prevent torsional forces while putting the IOL. So this is the IOL which goes in capsular bag. Again you do put some Miocol and this complete the case. This is a slit lamp video. You can see that this was the posterior capsular axis which I did, teardrop kind of posterior capsular axis, but IOL is nicely sitting in capsular bag and it's well centered. So I think with this I'll finish my presentation here.
Thank you so much, sir. I think one point that didn't come out in the last three and came out very beautifully in this is the use of pilocarpine at the end of the surgery. I think that is one important step everybody must have used, but you have captured that into the presentation. And now I would like to ask Suresh sir for his comments before proceeding.
Again, nice presentation. It was like three different procedures, and the lens, the three-piece lens, injecting the three-piece lens into a split like this. There is a limbus to limbus split. Is a little tricky, and the leading haptic, you have to guide the leading haptic either into the back or into the anterior capsule or into the sulcus or into the iris. So that is very important because it can even slip into the vitreous cavity. And if at all you are placing a three-piece lens in the back, if there is a vertical split, so you have to orient the haptic of the lens in such a way that it is 90 degrees away from the split. And have anybody tried putting a single piece lens in the sulcus with optic capture? Of course, it is actually not recommended, but I have done it in 3 cases, and even I have published the long-term outcome. There is no uveitis or no recurrent irritation, and the lens is very stable. The first case what I had was it was a total cataract, and the low powered multifocal with the toric power. So while injecting the lens, the distal, the proximal haptic got cut. It's broken, and so we had no option but to place the lens, because the patient is also from a distant place, and it was a low powered lens. It was not easily available. So the company people told it will take 15 days. So I went ahead with the same lens and placed in the sulcus with optic capture. It stayed very well, and there was not even 1 degree rotation. It maintained well, and there was no uveitis, no recurrent inflammation, nothing. The patient enjoyed six parts throughout. It's almost 1.5 to 2 years. And following that, another 2 cases, I have placed the lens in the sulcus with the optic capture. This is a single piece lens. Anybody's experience?
Dr.
Of
Shirish,
course,
which
it's
lens,
not described.
which company
Yes,
lens
sir?
was this?
It
Which
is
company lens?
biotech toric lens, the acryl toric lens. Yeah, two of them, and one is from Care Group, the other one. So
So I think these are the study which came up, giving against using hydrophobic lenses is because of the haptic of those hydrophobic lenses, which are very thick and which causes
no,
maybe
that's
that
what. It's
that
a
biotech lenses
bulky.
haptics are different and thinner than.
I have
No,
ended up
the
using a
classic
few cases, sir.
description is yeah.
So
Because
in the
like it
cases,
stays very well, and if your optic like capsulorhexis is small, it stays very well. If it is a large capsulorhexis, then of course it's out of question. I can't place it. If it is a small capsulorhexis, less than 5 millimeters, definitely you can try this in such situations.
So can I just make a few comments?
sir. Yes, sir. Yes,
Okay,
sir. Please,
number
sir.
one,
Yes,
you
sir.
should always have two lenses of the same type that you're planning to implant. If one lens gets damaged, it
Yes.
falls down, the haptic gets amputated, or there is some fissure in the optic, you can take it out and put the other lens. So that much we need to do for our patients, number one. The number two is the first case that you mentioned, Shirish, was haptic was damaged, is it?
Yeah,
Haptic
haptic.
was damaged.
Yeah,
So that
trailing
means
haptic.
it was not a 13
It is
millimeter
broken. It
lens.
is broken. Just
Yeah, so
close
it is
to
not a
the
13
optic. It is
millimeter lens, it
broken.
is a less than 13 millimeter overall length, isn't it? Normally, we don't
Yeah.
put anything in the sulcus that is less than 13 millimeters. Okay, so
Yeah.
now you have a lens which is less than 13 millimeters, which doesn't fit the sulcus well, which means it will be more
Exactly.
mobile, which means there is always a possibility of a latent or a smoldering UGH like syndrome which will manifest in times to come. Okay, so I would not advise. See, you are expert and you have a huge
Yes.
practice. If one patient doesn't do well, it doesn't impact you. But now for
No, you have
youngsters who are trying
careful
it out,
follow. Hmm.
they're trying it out. I think it is not a very good idea to. So there are two things. One is when you have adequate PC, you can keep the haptics in the sulcus, and sorry, in the back, and have a reverse optic capture. So that is also controversial, but many people do it. For example, if it is a toric lens and you have to keep the lens, there's nothing like you have to keep the lens, but if you want to really keep the lens, and if there's adequate support, normally it requires 2 to 3 clock hours of posterior capsule to support each haptic if you're putting in the bag. So you can put in the bag and then have a reverse optic capture. But again, with such a bulky optic with such a square edge, it is again playing with fire. And second thing is, if you don't have much of PC, then as Sirish had mentioned, you put the haptic in the sulcus and have a standard optic capture. All right. So that again, it is again you're playing with a certain lot of uncertainties will be there. What happens in the long run, we never really know. See, for example, now we having this dead back syndrome coming back to us after 15 or 20 years. We thought we're all safe. So I mean, the patients live long, and they're young patients. Many of these post-polar cataract patients. So that is something which one can do, but which one must be aware what is going on or what could happen. And as regards the three-piece lenses, sometimes I mean it may not be a very bad idea to keep the lens in the anterior chamber to start with, because if you're not very if the PC rent is large size, and supposing if you are not able to visualize the margins of the PC rent and you don't see the anterior capsule for you to slide the leading haptic into the sulcus, it may be a good idea to just keep the lens in the anterior chamber and then tuck the haptics in the ciliary sulcus. Now if you start rotating it, for example, so that leading haptic has gone into the sulcus, and then you start rotating, and then at any point, if the haptic encounters the area of the PC rent or the peripheral PC rent, then it goes into the bag, or it extends that particular area of the defect. There could be problem. So what I would do in those situations is, I would perhaps put the lens. I mean, it varies from case to case. I'm not telling that dogmatically that every case has to be done like that, but it makes some sense to put the lens in the anterior chamber and then tuck the haptics into the sulcus. You don't have to really dial it also.
Thank you, sir. I think one tip that my father actually passed on to me from Arup sir is sir carries 5 lenses to his OR for each of the patients, like one backup lens and then one three-piece, and I think one iris claw as well for all the patients. So that is a very good habit, sir, that from you I have learned through my father. And all of my patients have a backup lens and a three-piece lens standby, and even in routine cases.
I'm so
So,
happy.
Harshus, yes. So, Harshal sir, I just wanted to ask, this is a lost art actually, like how you showed actually how to load the three-piece lens in the IOL. So I would just like you to highlight it for the viewers, because that we generally learn to load the single piece, but three-piece most of us don't know how to load.
Yeah. So I think I'll again share that video quickly. Can you see my screen and come to that point?
Ye-
I think I skipped
Yes,
that
sir.
part, because of.
Yes, sir.
So, so this is the way the leading haptic goes, and this so trailing haptic, it comes out on left side of this knob which is there, and it remains over the plunger which is there, and this plunger, it goes down, goes inside, and it pushes the IOL. So when the lens is coming, so wherever the horizontal is, you need to rotate your hand and keep it horizontal, it if you don't do that, if you just try to keep bevel in one, in one direction, it may be the haptic is coming down like this, so then it will go directly in there. So you always have to rotate your hand and try to keep it horizontal. So wherever it is, you keep it horizontal, and then slowly you just go just ahead of center and let the haptic come out beneath the pupillary margin, and then optic unfolds, so you need to rotate it in anti-clockwise direction. So if you try it outside the eye also a few times, I'm sure you'll get used to the maneuver and direction in which you need to do it, and it becomes very useful when you really need, in situations like
Yeah.
this. So you should try
Yes, sir.
to take length. Yeah.
Can I just add one point? Actually, this is the type B cartridge of the Alcon, if not mistaken.
Yeah, C
Even in the
cartridge can be
type,
used.
yeah, even the C cartridge can be used for the same thing. But just as Sir was mentioning in the video, there is a small knob where you can engage the trailing haptic. But in the C cartridge, you just have to push it aside, and it does stay when the ion is going in. Only
Yes.
sometimes what happens is the metal plunger which is there, it can get entangled into the distal haptic. So we need not panic at that time. Just as we keep injecting, it itself detangles. Sometimes, as a beginner surgeon, people do get scared that what is happening here? Is it going to get
I will
stuck?
also get scared. After 30 years of Phaco, you saw if there's a PCA, uncooperative patient, and
Right, sir.
the
So
trailing.
I would make a suggestion like something that help in our institute is we have a package of a three-piece lens. So even in normal cases, we are putting three-piece lens. I think that is a good practice to do so that you get a hang of how to load a three-piece lens, how to inject, how it comes out, how to dial it in. Even in routine cases, if you do it, then if there is a PCR or any other problem, it will be much easier.
Yeah. See, I use the AR40E lens, that is a much more sturdy lens compared to this particular lens from whatever company. So AR40E basically is a sturdy lens. Only thing is it requires an incision. 2.8 millimeter is not enough. It may require a little larger, maybe 3 millimeters. For others you'll have to really squeeze in, the OVD comes out and there is a PC rent, AC becomes shallow. So I would extend the incision to 3, and then subsequently maneuvers go on pretty well.
Yeah.
Yeah.
There is a
So
comment, sir,
many a
from Dr.
times
Sanjay.
we do use. Yeah. Nilesh, go ahead.
No, sir, just he was telling that sensor three-piece that AR40 is not available of late. I think the
I've got a
availability
library
again.
here,
Yes, sir.
some
No,
some
no,
from
But
it's
the
time to
available.
availability
time.
again has come. It has come back, sir. The Technos
Yeah, from
three-piece
time to
was
time it goes off
released.
the market, but
Yeah.
then I made a stock actually so that I can oversee this periodic shortages, so it doesn't affect me.
Hmm.
Yes, sir. Harshit,
So
sir, you.
whenever we have a high myopic patients like -1, -2, so most of the time we use these three pieces only. So in between, I think surgeons, they of course have to use three-piece lenses. Yeah,
So
Nilesh.
Yes, sir. So I think so. With this, we have come to the end of the session. I would just like to have a quick comment from both Arup sir and Surish sir about how the session was, and Dr. Vanishri Nair, she had coordinated the entire module. So Arup sir, your
So,
And
comments
I
first.
think let's take comments first. Let us share the Google form for all the
Google
attendees
form.
which we have
Yes, sir.
attended
Yes,
on
sir.
Zoom. So because
Yes,
this
sir.
is a certification course which is testing
Yes.
the basic knowledge and about this subject of all the attendees. So
Yes, sir.
Sunilji, can you please share the Google form?
Yes, sir. All platforms.
Yeah. Please, all the
Okay.
platforms. So, all the attendees, thanks for joining. And this is a Google form which has 20 questions on post-polar cataracts. You need to finish it in 6 to 7 minutes by the time we finish our discussion. Thank you very much. Yes, Nilesh.
So, sir, Arup sir's
Incidentally,
comment.
Harshul, both Nilesh and I are in Bangalore. We came back to the hotel
No,
room, and it's a
no,
lovely
I'm in
program.
Jaipur, sir. I'm in Jaipur.
You're at home. We're
So,
not at home, but
Yes.
we're at home with your
current,
programs. Nice program.
Surish sir.
A nice initiative, Dr. Harshul, and it was nicely coordinated, Dr. Nilesh and Vanashri. So it will be definitely useful for the younger surgeons, and all presenters have shown difficult cases and how they have managed, and so the outcome of the procedure is also like almost all the cases went with the lens. So it's a great learning for younger generation. Thank you, Harshul, for making me part of this.
Thanks to
Yes,
you for
Harshul.
taking
Thank
out
you.
time from your
yes,
busy
sir.
OT. Thanks to Arup sir and thanks to other panelists also.
I
Thank you
think we
so
had
much,
very
sir.
wonderful comments from all the expert panels, and I think all the four cases had so much of meticulous. The flow of the events was quite slowed down, and each step was shown. I think all the participants would have a great, enriching experience today to take back. One thing I would like to add is many a times when we see a PPC case, we are all scared and troubled in our heart that, oh, now what is going to happen, or is it really going to go our way, or is there going to be a rent? But most of the times it is a type 1 and we get away with it. So I would like to comment to the middle level surgeons that don't become complacent, that till now I didn't have a rent, or this PPC also will go straight, and you don't land up counseling the patient or not emphasizing the factors. But I would say every case, whether you're doing ASOCT or not, if it is a PPC, most likely, with a clear edge and not having any posterior subcapsular component along with it, then I think keeping a three-piece IOL, counseling the patient, keeping a VR backup is very important. If everything goes right, well and good. But just in case things are not going your way, it is very important that we have counseled the patient and have the consent as well.
Wonderful.
I think a
And
very valid point made. I think, sir, I showed the video in one of the sessions with in when going get up that white cataract now I consider unless and until I see the PC I consider it broken and all the
Bipolar.
precaution needs to be taken
uh,
needs to be taken.
yes.
So one important point in white
So,
cataracts, what I learned was that do not, rotate the nucleus. It's not required,
Yeah.
or don't even do a hydrodissection.
so that's I think we have 2 minutes. I'll just quickly show what not to do, I think I've taken that off. So there are situations like Nilesh said that we do have cases where white cataract, we don't know that what lies beneath. So this is, I think, there is one case. Yes. So this is a mature cataract, you can see. So I start Phaco, start drilling, do what I routinely do, drill in center and try to chop the nucleus. And as I'm trying to, I can see that it's tilting down, no? Nucleus. On this side, I can make out that it's tilting down. So that gives me clue that yes, something is wrong here. No. So the second time I just try to go and chop, you'll see what happens. So that's you never know what is there behind these white and this cataract where you can't see the posterior capsule. So we do have VR backup. So what I want to show here to all the attendees is what not to do. Don't try to just scoop out this nucleus at this stage that it's half hanging down. You can go and try to take out with wire rectase and large incision. No, nothing. Now it's gone out of your domain. Whatever has gone behind now, half of the nucleus, you just need to close this case, give a call to your VR surgeon that has come, and they need to take it out without any long-term complication in this case. So I think this is what we all should know, that what not to do also. It's not that always you need to take out this nucleus. So this can happen.
Harshul, this case takes me
Yes,
back
sir.
about 32 years, 94 beginning.
Yes.
I had a patient
Yes,
from
sir.
a camp, I still remember, a 75-year-old Durgamma. If she's alive, she'll be 100 plus. So I just did hydrodissection and the whole nucleus dropped. It was the first time.
Yes.
That time there's not much of literature on PPC, and I thought it is a routine case. So then after the mishap, then when I examined the fellow eye had a typical posterior polar cataract, grade 4 nuclear sclerosis. Then I asked the lady. He said, yes, right from my younger days, I was not able to see well, there's glare and all. And then they had postponed the surgery, and it can happen. So mature
Yes.
cataracts have to be relieved. See the fellow eye.
Yeah.
I think that is a good clue.
Yes. Sunilji, how much time is there?
Sir, another 2 minutes we can keep it.
Okay.
The responses are coming, so I'll close it at 5 exactly. 14
5 or 4.
Turn off the live streaming.
Okay,
4
sir.
o'clock.
Turn off the live streaming.
Yes, sir.